Hello everyone, my name is Christine and my team members are Sam, Gloria, and Steven, and as a team we are Group Be Better. Today we are going to be talking about reducing catheter-associated urinary tract infections in the hospital setting. We chose this topic because we believe that all care should be received without harm to the patient. Any infections the patient develops can greatly hinder their recovery time or could even be detrimental to their life. Reducing these infections will save the hospital money, reduce waste from treatments that should be unnecessary, and most importantly, increase patient safety. First, let's look at the baseline data to get an understanding of our starting point. Although the specific infection rates associated with catheter insertion vary by hospitals based on protocols, or can even vary within the hospital, some baseline data is available about its prevalence in general. According to the CDC, 15 to 25% of patients receive urinary catheters during their hospital stay. This is a significant amount of patients receiving catheters, which means many people are being exposed to the possibility of developing a CAUTI. According to HealthCom Media, 1 week of catheterization causes a 25% risk of developing bacteriuria, and 30 days after insertion, there is a 100% chance of it containing bacteria. They point out that although this does not necessarily mean the patient will have a CAUTI, 10 to 24% of patients do develop a symptomatic CAUTI caused by this bacteria. In addition, the Washington State Health Association stated that up to 69% of CAUTIs are preventable. This is a staggering number and the reason why we believe this change process needs to happen. As I discussed on the last slide, the issue of CAUTIs is very prevalent and the vast majority of them are preventable. Some people might say, well, it's just a simple UTI, what's the big deal? Well, there are a lot of reasons why this is a big deal. The Agency for Healthcare Research and Quality released an article about CAUTI prevention, and they stated 4 main consequences that occur as a result of a patient getting a CAUTI. This includes longer stays for patients by up to 2 to 4 days. This is a problem because longer stays mean more complications can occur in that time, such as developing other infections. Patient discomfort is another consequence, and this can be difficult for the patient to deal with while already going through pain. Excessively high healthcare costs go alongside the first 2 points because longer stays mean higher costs for the hospital and 1 less bed that can be used for another patient. The treatment of the CAUTI also has a cost as well that insurance does not cover. Last is the most important consequence, which is increased mortality. When someone is already very ill, an infection can be detrimental to their life. This is why it is so important for us and other organizations to find ways to reduce the occurrence of CAUTIs. So, now that we have covered what the baseline data is and why this change is necessary, I will be discussing what our tentative plan is. For our trial, we are going to use the Schuhor cycle, or PDCA, the Plan, Do, Check, Act method of change processing. The plan section is about gathering the baseline data, determining the root cause analysis, and a hypothesis for what we think will work to decrease the amount of CAUTIs. I have covered the baseline data, and Steven will discuss the root cause analysis and hypothesis. Next, Sam will be discussing the do aspect of the plan that we developed based on our hypothesis, and he will talk about how we will be tracking and measuring the data along the way. Sam will also be doing the check section of the trial by determining if the hypothetical trial was successful or not, based on our criteria. Last, Gloria will be discussing what we plan to do next based on if our trial was successful or not. Then she will be summarizing our trial process and wrapping everything up. Next, Steven will discuss the root cause analysis for our trial. Steven?
Thank you, Christine. My name is Steven Osei. Next up, I will talk about the root cause of CAUTI and also discuss our hypothesis. According to University of Missouri Health, CAUTIs increase patient discomfort, increase antibiotic usage, contribute to antibiotic resistance, increase the length of stay in hospitals, and are reportable healthcare-acquired infections. CAUTIs are the most common hospital-acquired infection in most of our healthcare facilities, as Christine has already highlighted. For us to arrive at why CAUTIs is just prevalent as Christine talked about, we need to analyze or identify the conditions that lead to CAUTI. Using the fishbone, we can discuss the cause and effect of CAUTI by answering the questions of why and how on each general category of the fishbone will lead to CAUTIs. Insertion of cavities, daily maintenance, patient fat tests, as well as removal of cavities can all result in CAUTI. Based on the cause analysis, we will focus on the timely removal of cavities because the risk of infection increases each day a patient has a cavity. Cavities left in too long and their removal not addressed daily increase the risk of infection of a patient. If a patient does not have a cavity in place, a patient cannot get CAUTI. According to Glue and Co. in their article, Risks and Benefits of Early Cavity Removal After Renal Transplantation, they outline at least 3 main reasons to adopt early cavity removal after renal transplantation. 1. To decrease the risk of perioperative UTI. 2. To facilitate early patient ambulation after surgery. And finally, 3. To reduce patient hospital stay. Almost 60% of septicemias after renal transplants are due to UTI caused by the presence of urethral cavities. Early removal of cavities also decreases antibiotic usage and limits antibiotic resistance. Moreover, timely removal of cavities saves patients, their families, and other stakeholders a lot of healthcare costs. The above reasons demonstrate that when it comes to CAUTIs, removing the cavities on time facilitates patient treatment and saves lives. In order to decrease CAUTI, our focus will be placed on effective utilization of cavities. According to Scullis in his article, CAUTI Surveillance in 2017, he emphasized that each day an indwelling urinary cavity remains in place, a patient has 3 to 7% increased risk of acquiring a CAUTI. Thus, cavity utilization protocols that promptly remove cavities decrease CAUTI. If we reduce the number of days cavities are in place by nearly 1.5 days, we can then decrease CAUTIs by 25%, which is less than our benchmark, according to our data, which Sam will talk about shortly. Developing effective protocols and implementing electronic reminders in facilities EHR and improving compliance with regular assessment, we can expect to achieve a decrease in CAUTIs by 25%. Sam will take over from me and discuss the trial specific. Sam?
Thank you, Stephen. Despite the strong link between urinary catheters and subsequent infections, many hospitals in the United States do not have established systems to routinely monitor the placement or duration of urinary catheters in their hospitalized patients. Our focus on this trial is based on the goal to decrease the incidence of CAUTIs by decreasing the amount of time the catheter is in place. In 2007, the Michigan Health and Hospital Association Keystone Center rolled out a statewide initiative known as the Keystone Bladder Bundle Initiative to reduce the number of CAUTIs. In 2008, the Centers of Medicare and Medicaid Services decided to no longer reimburse hospitals the expense for treating patients who acquired a preventable infection during their hospitalization. Fortunately, those hospitals who were involved in the Michigan statewide fight to reduce CAUTIs in 2007 benefited from the results. Comparing the difference in CAUTI prevention practices between Michigan and non-Michigan hospitals, Michigan hospitals had a more successful decrease in CAUTIs utilizing practices based on decreasing length of catheter insertion. Practices such as routinely monitoring the duration and/or discontinuation of urinary catheters, the use of portable bladder scanners, as well as catheter reminders or stop orders, and/or nurse-initiated discontinuation. As Christine mentioned earlier, a significant amount of hospitalized patients receive urinary catheters during their stay. If we could reduce the number of catheters given or reduce the time the catheter is indwelling, it can greatly reduce the incidence of CAUTIs in hospitalized patients. It could also increase quality care and benefit recovery time for patients, as well as minimize the hospital's financial burdens associated with CAUTIs. The new practices and criteria of this trial will be sent out to our nursing staff, along with a notice that catheters should be removed within 30 minutes after receiving a stop order. This trial is 2 years in length in order to gather enough data to ensure that change was successful and sustainable. The research demonstrated from baseline to the end of year 2, following the intervention, urinary catheter use decreased from 18.1% to 13.8%. So we expect similar results because we will be using the same methods to decrease the CAUTI. As mentioned earlier, during the trial, we monitored the percentage of CAUTIs in relation to the length of time the catheter was in place. We also monitored the time between when the takeout or stop order was put in and when the catheter was actually taken out. Not all patients who acquire a CAUTI have the same age, sex, or health status, so we will be recording those outside factors as well. This information is recorded into the patient electronic health record, and the Director of Quality Assurance could pull up the patient demographics and data regarding the start and stop of the catheter and decipher if the CAUTI rates are increasing or decreasing. Once the Keystone Bladder Bundle Initiative concluded, the results revealed that more frequent use of preventative practices coincided with 25% reduction in CAUTIs in the state of Michigan, a significantly greater reduction than the 6% overall observed in the rest of the United States. Based on Michigan's improvement utilizing these methods, we expect the same, a 25% decrease in CAUTIs. The aim for this trial was the timely removal of urinary catheters in order to reduce the number of infections, and at the end, we were able to observe that more frequent use of key prevention practices coincided with a lower rate of CAUTIs. Based on the numbers from the Michigan study, we had expected a little more than 200 patients acquire a CAUTI, but to our surprise, we were only able to observe 150 patients acquire such infection. As mentioned previously and displayed on the graph on the slide, our goal was to reduce catheter-acquired urinary tract infections by as much as 25% when compared to our baseline, and we did. This meets the criteria for a successful outcome. Next, Gloria will wrap up our presentation by mentioning recommendations to follow our trial, as well as mentioning the lessons learned. Thank you.
Thank you, Sam. In this slide of recommendations, based on the outcome and success criteria, should the change be permanently implemented? Since the trial went successful by reducing the CAUTI by 25%, it should continue to educate staff in training and make it a requirement for all new staff to learn the knowledge of preventing infection in the CAUTI, and also expanding new ways to reduce it for the future. If the outcomes have been unsuccessful according to criteria, there should be more in-depth of studying about infection prevention caused by catheters. This new strategy will involve being more strict in monitoring patients with 24-hour care to see the best results in reducing infection. To ensure our permanent changes with training and educating staff is still useful and effective today, we will be checking the CAUTIs percentage constantly and continuously to see if anything has increased or decreased. That way we know what to improve in educating and training our members. We will also be checking the percentage of CAUTI after setting a policy guideline for nurses who rotates in the monitoring patients who has catheters. Also double-checking nurses' documentations in the record to identify when the nurse are actually taking out catheters after the order is put in. Lastly, gathering surveys from all clinical health professions to see if training and education was helpful or not, and asking staff to give feedback on what we can do to better their learning in CAUTI. To sum everything up, what we did as a team, we looked into evidence of CAUTI, defining what it is, what the main problem was, and what we were trying to solve. We came up with hypotheses and theory of what we thought may work best by doing this. We tested the trial 2 years max while collecting all of the data and sources to see if our hypothesis was accurate, which the results came to reducing 25% infections in the CAUTI. While the trial was going on, we learned the baseline data of how much bacteria can increase by the length of the patient's stay. We also learned a lot from looking at the bar chart, run chart, and how much the strategy had decreased the infection rate. We learned that it is important to account for factors that can contribute to the UTI rate so that we can accurately assess if our trial is working. After the trial was done, it is important to figure out how to implement the new policies within the entire hospital in order to keep the infection rate down. Also, continuous monitoring of this will ensure new policies are still being used and are still successful today.
Thanks, Gloria. Attached here are our references. Thanks for listening.